right? So it's the basic goals of orthodontic surgery. Audible? Is it audible? Yes. So basic therapeutic goals of orthodontic surgery. So ideally this should be taught first itself. I told because this was my topic, the maxillary mass services. So that's why. So why you do orthodontic surgery? Why? Yes, function. But basically we get most of the patient 18-20. Myself during my time, I wanted orthodontic surgery. My parents they did not allow. So basically it's a aesthetics, but not aesthetics, but essential. Most important is to establish the proper function. Definitely establish a patient aesthetics. Provide stability. Stability means, see, now you pay income, that's why the relevance of the vital surgery to reduce the relapse. So there's a very chance of relapse. So suppose you do a setback of 8-10 millimeters, mandible setback, there's a very chance of relapse. So you have to do the procedure thinking of the potential chance of relapse.
A small announcement, please. The snack which is supplied looks like a meat roll, but actually it's a vegetarian dish. Anybody can have it, okay? It's a vegetarian dish, just for information. Thank you.
So that's why. So that's why. Suppose if you having a reverse overjet of 8 millimeters or 9 millimeters, what is doing a mandibular setback alone. But the problem is that you need a 2 mm setback. I mean the overjet correction is needed. So you have to always keep in mind whether the patient or definitely orthodontist will come say about relapse. So always you should think about relapse also before planning history of orthodontic surgery. First one was done orthodontic done in United States of America is Lancaster. First mandibular osteotomy by what you say, case of Abdin Ockerby. 50 years later, Blair, who has done extensive study on orthodontic surgery, vascularity, he has done osteotomy of mandibular osteotomies. So there are so many variations are there. One Blair is there, Ernest is there, Lincoln is there, Rasmus is there, Hofer is there. There is vertical transfer. The common procedure that we do is bilateral sagittal split osteotomy. That was put forward by Opweisler. But there are various modifications from time to time. So goal of doing a bilateral sagittal split osteotomy, main important is the preservation of inferior neuron. So over a period of time, Opweisler is there, Dan Point is there, Hansen is there, all has modified bilateral sagittal split osteotomy, but basis was one by the Opweisler. So many people are there. So that is why I previously said that aesthetics function as well as the stability. Principles of treating mandibular deformities. Patient's perception of deformity and expectations. See, That is the most important thing. See, you take a patient in an orthopedic surgery, the patient's perception. You put the patient in a surgery, you should understand what the patient demands, what patient wants. Will you be able to deliver the patient expectations? You should be extremely careful. See, many of the patients will be 18, 20, 22. They will be seeing YouTube or Pixar coming up. See, but there are limitations and their expectations whether we are going to satisfy. That is the most important. The psychology and counseling, all these are mandatory. Another thing is surgeons' organization of the deformity. See, suppose if there is a class 3 malocclusion, it can be either a maxillary excess, mandibular excess, or no. Class 3. Class 3 means mandibular excess or maxillary deficiency. So, you should be careful. You should either do a class 3 means it is not that it is a BS, so it should be done. It is not that. You have to check with the maxillar deficiency, and maxillar deficiency treatment is different. What you do? Maxillary advanced. So treatment is different. The patient random 3, you just see. If that's where the relevance of supplementary tracing comes. You have to look at which virus. Shankar sir may have said which virus. SNA, SNB, all those ANB, all those stuffs has to be evaluated, and you have to think whether it's which one either it's a maxillary deficiency or a mandibular excess. So you have to be careful with doing fixing the procedure. Supplementary treatment analysis, optimal treatment plan, counseling of the patient, and most importantly the informed consent. Patient may come and say, my old face is better. So this is the anatomical considerations where vascular structure is there, muscles is there, nerves is there. Which are muscles are there? Related with this. Yes, exactly. Medial what? Okay. Okay. Then vascular structure.
Inferior neuron.
Inferior vascular artery. Right? And nerves is nerve. Okay. Ventral nerve, regular plastics. So this is the vascular structures. Where demonstrate that mostly what happens, demonstrate the blood flow through the mandibular periostea and maintain a sufficient blood supply to the teeth and the structures. You can see that, and this is the arterial supply. Vascular supply is the proximal segment of medial supply to the temporomandibular joint capsule as well as the attachment of the lateral pterygoid and inferior. So basically we can go for it first. Another important is determination of safe distance away from the effects of the teeth. The safe distance 5 millimeters is possible, 10 millimeters is not possible. If you get it, it is better. But obviously safer distance is 5 millimeters. So you have to always maintain a 5 millimeters vascular attachment, and it has to be preserved. The safe distance is around 5 millimeters. This is the, you can see the inferior nerve, buccal nerve, medial nerve, as well as the myelin nerve, and you can have the ventral nerve and the incisive nerve plexus. So this is the question when you are doing a bilateral surgery, just So, which of cases you prefer BSSO? Either BSSO,
Mandibular proprioception.
mandibular proprioception, you will be doing a setback. Okay, then mandibular
Retrograde.
yes, okay. Retrograde, very good. Retrograde, you are what you will be advancing. Next,
Obstructive sleep
you
apnea.
can differentiate asymmetries, transverse corrections.
Obstructive sleep apnea.
Many, see, it's a very versatile procedure, BSSO. So, most important thing is how will you do a BSSO? How will you do a BSSO? How you are doing an incision? So, there are, before doing a BSSO, you have to be very careful whether you are going to keep the third molar there or not. Ideally, I prefer 6 months to 9 months extraction. Why? To prevent the bad split. Still, if it is not impacted, definitely we can do. No issue in that. But preferably, when you are a beginner or a starting phase, it's always better to remove the third molars. Ideally, 6 months. And definitely don't do within 2 weeks of the patient will come back and say that I am going to go to that. You do an impacted third molar 2 weeks before, then plan for BSSO. That is more dangerous. Either you do 6 months or before, or you do how you plan. Suppose if there is impacted tooth.
Tooth should be considered as well.
Yes, you have to consider tooth as the bone and split the tooth. That means that you have to see, you have to think that there is no tooth. You have to consider tooth as bone and cut through the tooth. Another important aspect is suppose you have to calculate the how you put an incision. Obviously, you have to put an incision. Yes, anterior back, you have to calculate the. Okay, put an anterior incision. Okay. Then extend anteriorly. You raise the periosteum. Okay. Identify ligula, yes. Before that, you have to sometimes ligula. Before identifying the ligula, you have to raise something up. Mucopharynx, okay. Mucopharynx, still, which muscle? Which muscle you have to raise up?
Temporal.
You have to put a trans, 4 trans retractor, you pull the temporalis muscle. Right? Once you have pulled the temporalis muscle, you can detach the temporalis muscle. Then it is better that you can remove the lingual periosteum, or we call the lingual periosteum, and search for the lingula. Once you have identified the lingula, what you do? You put the median cut anterior to lingula or posterior to lingula. Why? What happens if you put the anterior? Then you can put anterior. Now, so many variations are there. That you might be confusing, it might be confusing to you, but that's a conventional thing. You put a posterior incision, median cut, then you have to come anterior. Come anteriorly. Lateral aspect, it has to be there. Cut to the lateral aspect, and you have to reach up to the. Depending upon, it's always better you come little anterior because fixation will be more easier. Otherwise, sometimes you are doing a setback. What happens is that you have to remove the chunk of bone from the, that will be difficult. So, you will come anteriorly, and some system is distal aspect of system, then you move in the vertical direction. So, throughout this slide, you will be cutting only the one bone. I mean, you will just the cortex only. And as you reach the down, the vertical aspect down, you will be putting the J cut. Then J cut, what will be doing? You will be removing the goat, lingual and bucket. What happens if you are not there?
It will split.
Bad split occurs because you have to, this has to be sprayed down. So you make it cut, so very careful. Complete the cut. After completing the cut, what you have to come, you will have to again start with the smaller osteotomes. First initial stage, you put a bylock so that you can get the regular area. So you 4 millimeter osteotomes, small osteotomes. Then once you come there, next step you take a larger osteotomes. And after that, split spreader, if you need split spreader, you have to be careful using that instrument. How many prongs it have? 3. 2 goes to the stronger section or weaker section. 2 for the spread, 2 goes for the weaker section. 1 for the stronger section. Okay. So you what happens? You do a split spreader. You split the mandible, becomes 3 pieces. Then what you do? Yes, very good. You have to check the what is there, the median section of the, ideally it has to be the median. If it is lateral, you have to dissect it, get into the median aspect. Then what is the segment? Next step is, what is the next step? Very good. Why? Very good, yes. Median pterygoid also. Possible you have to detach it. Okay. Okay, you push back the mandible. Next step, before fixing, what you have to be very careful. Patella? Sac. Yes, exactly. What happens? You have to check whether patella. Otherwise, what will happen? Exactly. So there's something called a central patella sac. There's something called a peripheral patella sac. So patella sac, you have to check whether it is inside the patella. Otherwise, what will happen? You will fix it in a wrong way. Okay, this is the position of the lingula. How will you identify it? So you can, otherwise, you can look into the area where you can see that the bone, both bones, buccal and the bone fuse, that area you can identify it is approaching the lingula. So this you can see the lingual ulcer. So this is revascularization and healing. So advantages of BSSO or bilateral scientist it is that you are getting, yes, it is been, you can take close proximity, so healing is better in such cases. So intermediate circulation between the proximal and distal segments, margin of osteo, 1 week postop, level of hypervascularity around the cervical edge, no soft tissue reattached, isolated area of subclavian reform. 2 weeks follow-up, avascular zone, necrotic zone at the distal osteotomy site, no soft tissue attached at the distal necrosis site. 3 weeks follow, soft tissue reattached, vascular anastomosis between the proximal and distal segment and osteal formation to the bone values. 6 weeks, 12 weeks, circulation with the becomes continuous by 12 weeks. So there is procedures, vertical ramus, osteotomies, anterior subapical osteotomies, posterior subapical osteotomies, step osteotomies. So various one, genoplasties. So this is the various verification variations of VSSO. So this is the 10.1 advanced technical workshop for our rating and related to land cortex. And so shorten the cuts through the radial cortex to fully the mantle for land. Bells and electrodes and modification is done. This is the procedure is done. So now the fixations. See, fixation, either you can see, always better to do a rigid fixation. During my initial, when I was a student, basically wires were used, but now you can definitely the rigid fixation is there. So 2 mm there are screws with 6 mm or 8 mm diameters. Recently, we also with more reactive bomb plates and screws, not very near much. Indications. 3D strength, mandibular deficiencies, asymmetries, definitely open bite, cross bite, mandibular prognatism. Yes, this is the cases where contraindication, where severe decreased posterior body osteotomy, severe reduction, where you might not be able to split it extremely thin, the median and the lateral width of the bone. What will happen if the median and lateral width is less? What will happen? You will not be able to split properly. There is a big chance of bad split in such cases. Yes, sir. Severe rank hypoplasia and severe asymmetries. This is the incision. This is the medial incision. Sigmoid notch identified. Always you have a look onto the sigmoid notch. What will happen if it is your cut, medial cut is near to sigmoid notch? What will happen? Yes, what will happen? There can be either, if it is very near to sigmoid notch, you can fracture from that side. So there is a chance of back split or even a condylectomy, or that segment will come in one piece. Then it will become very difficult. So another important is that whatever happens, back split has to be managed. You understood? You cannot leave like that. So though you have to be very careful in handling cases, you should be competent enough to handle the back split. So suppose what happens, the segment condyle will come on the other segment. You understood? So in that case, what do we have to do? We have to do a condylectomy. You understood? Suppose what happens, this buccal plate will fracture off. Then what will you do? You have to put a long plate and fix it in the buccal segment. Suppose what happens if the lingual plate will detach. Suppose I said about 1 month, 2 months. Suppose the lingual plate from just distant to 7 it will crack off. Then how will you manage? You have to complete the cut from the again and push the minor segment back. You understood? Keeping that periostal that side. You understood? So 7 is cracked. So what happens? That chunk of bone will remain there. So you have to complete the cut and push so that otherwise the maxilla will not move back. So the maxilla, if you want to bring the mandible anteriorly, still that won't be a hidden problem. But you are pushing means that hindrance should be moved out. See, this is how you either you can do it the bulk away. This height, exactly. This is a horizontal cut, this is a vertical cut. Vertical cut, over the J cut, where you have to do a bilateral cutting. See, this is just splitting. This is the instrument cord. It's spreader. As you people said, have to be very careful in position of the nerve. If it is onto the lateral aspect, you have to push it back to the medial aspect. Mandibular advancement, okay. Setback means you have to take the piece of bone. Fixation techniques. Advantages, as previously said, healing is quick. 3 times flexibility and stability. Bone overlap is good. Prevention of the relapse. Okay, so we are left. Complications. That's we'll be talking in detail. The relapse. Previously said you have to technically relapse. So if you are pushing too much backward or pulling too much anterior, you should think of relapse. And if that too much is there, you have to think for the biosurgery. Nerve injury, obviously, it is there. You have to say regarding neuropraxias, neurotoxins, axiotomosis, temporal. There are various studies whether while you are orthognathic surgery, it is good for TMJ or not. See, there are two school of thought. Some say that it is good for the temporomandibular joint. Other people say that it is bad for the TMT. But it is dependent upon how you do and the stability and the procedures, how you do. That is also the surgeries. And also it's a quite important thing. This is the Ordella position, rotation of the concrete segment, Ordella stack, Ordella top. Malfusion can lead to skeletal relapse, malfusion hypomobility, remobilization of form. There is no exit, set Ordella sign, central Ordella sign. So you can see the sign of the median and the lateral fiscal. Malfusion can, that's a Ordella sign. Open bites can be due to either inadequate fixation or there can be a lateral shift, inadequate advancement of one side, equal bilateral midline shift or torsion of the proximal segment. The management, obviously, if that's a malfusion, one way is you have to put the patient in an elastic. Certain times, if it is too bad, then you have to go in for a re-exploration. You have to think of that in certain cases. Then severe orthopedic. Bastions. There's a fracture of the bucket plate, there's a fifth liquid plate, inferior segment, left in the proximal segment, Cordella segment, bastion. So bastions. It's a split comes around. Previous split of the cortex previously said fracture of the coronal process, distal segments, the labs. Prevention by proximal segment control, proper Cordella position, avoidance of Cordella rotation, decrease when to reach fixation, and myopathy and orthotic moment correction. Producer the temporomandibular function and hypomobility. Now damage. These are complications that which will be taking again. Again, when whichever position you get the nerve damage, whichever procedure during VSSO. Damage during the splitting of the material or the medial retraction of the soft tissue. Either you are tracking the soft tissue fully medially or during the procedure by identification of the nicula. It's a totally a buying procedure. We are saying nicula nerve can go either way. So we have a rough assessment how we are doing. So what happens? Suppose we are cutting, can come to the nerve. So that's why there's a chance of neuropraxis is there in VSS, so it's quite high. chance of lingular, low. That's why don't put a too lengthy needle when fixing the, screws. 12 millimeters above that, 14 millimeters, don't do that. 8 or 10 maximum, not more than that, because that's chance of, there's a high incidence of neurosensory disturbance in the bicortical as well as the monocortical space. So the reason for having the tear or nerve injury, prevention of nerve injury during that's a complication for that server will be taking details. Still, you have to, it's always better to reduce the chance of nerve injury. So following preparation of the subperiosteal at the medial side of the ascending ramus, prevention of stretching the nerve from the medial frontal tractus, non-related instruments and short should be only on the open the mandibular cortex. Osteotomy may penetrate only very superficially into the mandible during splitting. Removal of the impacted nerve. So this is usually done to prevent the nerve injury. Measures to, as I said, lingual nerve injury should be pressure, hemorrhage, disorder, complications, things. It is mainly due to the maxillary artery, retromandibular, and the facial vein. So what is vertical ramus osteotomy? So what are the most, which of cases you choose a vertical maxillary osteotomy? Where you are unable to do a channel or bilateral channel, you can do a vertical ramus. So what are the common incisions you give in a vertical ramus osteotomy? Either you can give a submandibular incision or retromandibular, okay, but okay, then preauricular, no. It's better to put a reference incision. Then, okay, now advanced methods are there. You can do intraoral also. You can have a piso, saws are there, so intraoral procedures also, intraoral also it can be done. So, how will you do it? Yes, what are the structures you have to do? From where you have to come down? Yes, exactly. From the sigmoid notch, lingular. Exactly, you have to come down. Can you do for the maxillary advancement? Yes. It is only for the setback. Why not for mandibular advancement? No bone for that. That's a simple thing. So, mandibular is for a horizontal maxillary, for a mandibular symmetry, mild occlusal discrepancies, failure to achieve the passive rotation after release of the patient with significant DNA contents. Contraindication, recent condylar fractures. Obviously, anterior you can do only a setback, you cannot do the anterior one. Okay, this is the procedure for a surgical procedure. You have to identify the sigmoid notch and lingula and so various modifications are there. This is the osteotomy you can do. Exactly. Okay. Give a fixation. These are the variations. So sometimes there's a relapse, you will have to effect of the temporalis. So also has to be detached. So in case of it, there's a relapse is there. This is a comparison between having a ramus osteotomy as well as okay, so complications again is a different part. Nerve injury comparatively more or less. It is less compared to BSC. Less incident compared to ganotel to osteotomy is close to the mandibular foramen. Medial displacement of proximus is compressing and the tearing the nerve. These are situations where you get a, otherwise mostly not. So, so if you are not seeing this, you can clearly delineate this. Really, obviously, since the external procedure is much more easier to handle. Really, common sources maxillary artery and proximal septum and control of toxins major disadvantage. That's a major disadvantage here. You cannot get a proper control of the. So it may be displaced anteromedially or it can be medially and medially. So that is the issue here. Condylotomy procedure that is done along with that. Mostly certain cases when you are doing TMJ ankylosis and reduction and along with that you are doing a BSS or D4 sometimes you have to do the condylotomy also. Condylectomy, when in cases of ankylosis, tumors, condylar hyperplasia, hemifacial microsomia, and it can be, now we can do along with the temporomandibular joint reconstruction. Other is less commonly done, that is vertical body osteotomy. What is vertical body osteotomy? Yes, you will be taking a through and through wedge. It can be mostly used for the mandibular setback versus where you are doing only the horizontal component. You understood. So in that case, specifically if the nerve is there, you have to identify the nerve and take the buccal as well as the lingual components of it. So you can to get a proper this thing is difficult in such cases. Definitely patient can have such issues. Anatomical discrepancies make bone to bone contact of this. See, this is the anterior body osteotomy. As you can see. If you have a piezoelectric, you can take a bucket, you remove the bucket, then you have to put the parallel osteotomy in the back. It has to be done on the either side and you will be pushing back. So it is not like BSS, so it is not that easy because it can reach out that direction. It is not that it might be easier, but it is much more difficult than the other BSS or other things. So one thing is that you have to identify the nerve, buccal part, identify the nerve, then you have to go for the lingual compartment. You do it bilateral. Can see how to take the buccal compartment, nerve identification, lingual compartment, then see it back. This is the variations of what is that here what can you identify this procedure? What is the advantage? You are identifying your exactly the medial nerve. You are doing a step and you are bringing it anterior to prevent the anterior nerve damage. This is the posterior osteotomy. Wires, you can wires or fixation. Okay. Other is subapical osteotomy. What is subapical osteotomy? Yes, most cases when your subapical osteotomy is needed in cases something like that. So this is subapical osteotomies. In case of subapical osteotomy, what do you do? Yes, then you extract the femorals. You take a bucket plug has to be taken care of. You detach the lingual component, extract the socket, you cut the vertical height. So keep a medial do the lingual cutting. Go around the anterior aspect, the other side, again opposite thing has to be repeated, then you push back. This is mostly done in cases where you are not having enough overjetting. You are doing a surgery first control or something, so you have to the subapical osteotomy there, or cases where you are not having a sufficient knowledge. Okay. This is by modification by code. Like in last exam, it was a codes procedure was asked. Yes, you are doing the subapical along with the genioplasty. Complications is loss of bone and teeth blocked vitality, endometrial paresthesia, might become fast. Posterior subapical osteotomy. Same as the anterior, you are, from the posterior wrinkle aspect, you are bringing down. This is the total mandibular subapical osteotomy. It's a very difficult procedure. From the digula subapical area, you have to round and come from the and you have to move as a whole. See, this is the procedure. This is a variation of this. This is see, the genioplasty is quite important. So this there is various types of genioplasties are there. You understood? Okay, you don't know various types of genioplasties. See advancement reduction genioplasty, dimensional genioplasties, types of genioplasties, advancement. Horizontal advancement genioplasty, we are bringing the genioplasty down. Or suppose the vertical height is a reduction genioplasty. Or horizontal osteotomy with anterior posterior reductions. Double sliding genioplasty, certain severe microplasia. Or you can do with the graft, vertical osteotomies, or the horizontal osteotomy narrowing the chin, or popular genioplasty where you will be doing the multiple dimensions. Complications, again, sir will be talking regarding the complications, bleeding, lingual soft tissues, postoperative complications. That's how we will be covering main complications. Conclusion. Bye.
Yeah, thank you, Dr. Lin. He had another 20-25 slides, but then since we have this World Finance session exclusively kept for 6:30 to 7:30 1 hour, so we have actually cut it down the presentation. But the PPTs that I told you, we send to you all. Lin,